All right, welcome everyone to the Cataract webinar. I am Jonna and I'm going to be the moderator today for Dr. James Burden. Before we get started, I wanted to just let you know about a great feature in GoToWebinar. There's an area on the right-hand side called questions. So as we're going through this webinar today, if there's anything that comes up and you want Dr. Burden to address it at the end, feel free to go ahead and just note that in the question section, and I will read it to him during really the last 5 to 10 minutes of the webinar. One thing I wanted to say about Dr. Burden, not only is he a cataract surgeon, he also is a glaucoma specialist, so he offers a unique perspective into cataract surgery. So without further ado, I would like to introduce Dr. James Burden.
Good afternoon, everybody. This is Dr. Burden. First up, thank you for joining our webinar this afternoon. So let's go ahead and get started. I'll take the next slide, please. Okay, well, what are cataracts? Cataracts are nothing more than the natural lens you were born with that has gotten darker over time. We're born with a clear lens, and like everything else with our body, it grows as we do. But unlike the rest of the body, it continues growing after we're an adult. And actually, it's more kind of like an onion in that it gets layer after layer as time goes by. And eventually, at some point, these layers begin to kind of darken and protein clumps up in these lenses. And eventually, they turn kind of brown, and it keeps light from reaching the back of your eye, which is where the images form. So there's a schematic diagram of a cross section of the eye at the bottom of the screen. And if you look at the right-hand side, you can see the cornea. That's the front clear window of the eye. And light passes through there. It then passes through the pupil, which is the opening in the iris, that colored part of the eye. And the lens sits right behind the iris, and it focuses the light on the back of the eye on a thing called the retina. So in this diagram, the retina is the kind of orangish tissue with the blood vessels present in it. And so truly the eye really is nothing more than a camera. And the lens focuses light on the film of the camera, which is the retina, and that's how we form an image. Next slide, please. So folks can have a lot of different symptoms with their cataracts, and they can be kind of unusual. The biggest thing we see is that folks develop cloudy or blurry vision. And this blurring sometimes manifests as just a feeling that you can't get your glasses clean enough, or that you just can't get a light bright enough to read by. A big thing folks sometimes see too, which can be very disabling, is glare or halos around lights, and in particular around headlights and things like this when you're driving at night. Not infrequently, patients say that they even stop looking at the oncoming headlights and just look at the white line on the side of the road simply because those lights are so bright and dazzling when they drive at night. You can also have a loss of color perception with cataracts. You're basically looking through a brown filter. And so colors like blue and such will desaturate and not look their real color. If you really have a specific type of cataract called a cortical cataract, it can even give you double vision even with one eye. And that can be very disabling, and especially when you're trying to drive and things like that. And another thing a lot of folks notice as they get cataracts is that they go through a frequent change in their glasses prescription, whereas normally maybe they got by for 2 or 3 years without having to change their glasses prescription. They suddenly find themselves having to change them every 6 months or something like that. And the schematic at the bottom of the eye kind of gives you an idea of color desaturation with a cataract there. Okay, next slide, please. Now, the interesting thing is almost everybody gets cataracts at some time in their life. They generally start to develop when we're in our 50s, and they just aren't visually significant until we get older. But by the age of 80, more than half of Americans have cataracts that are visually disabling. And in fact, worldwide, it's the leading cause of vision loss in adults over 55. So anybody in their 50s and beyond can actually have cataracts. They're just not visually significant, so they don't even know it. Next slide. Now, the nice thing about cataracts is they're not a medical emergency. Because they come on slowly, people can become disabled slowly and not really have too much of a problem until they suddenly reach one day where those cataracts drop their vision to the point that they come see somebody like me. The main thing we're looking at when people come to see us is whether or not those cataracts are really causing them a problem. And by that I mean, I always talk with my patients about what their visual needs are. and find out if they can see like they need to drive at night or to read and such like that. And every once in a while, someone comes in, and after we have a discussion about those cataracts, we decide to wait on their cataract surgery for a year or two because they're really doing okay. Next slide, please. Cataract surgery is, of course, how we take care of these cloudy lenses and remove them. And it's one of the most commonly performed surgeries in the country. Over 3 million people a year have them, so it's a very, very common procedure. The technology has gotten so much better even in the last 3 to 4 years. It's really amazing. When I started doing cataract surgery 25 years ago, the procedure could frequently be up to an hour long. We used a lot of stitches in the surgery on the front of the eye, and people really didn't get great vision for about a month or two. Whereas now the surgeries themselves are very quick, usually about 10 or 15 minutes, and the results are very quick after the procedure. Instead of having to wait a long time to get a good visual recovery, it's very quick. Next slide, please. So how do we do the surgery? Well, these days, it's very simple. We make very small incisions, usually 2, in the cornea, that front clear window. They're very tiny. We make them either with a scalpel or with a laser, but they're very tiny. One of those is 1 millimeter, and the other one is 1.8 to 2.8 millimeters. So very, very tiny incisions. The lens of the eye is then dissolved or broken up, depending on how you want to do it, either with ultrasound or with a laser. And then those fragments are removed from the eye, and we replace the lens with a crystal clear artificial lens that's typically made of acrylic plastic. And this lens stays clear forever, and once it scars into place in the eye, it's a piece of you forever. So very elegant way to do the surgery these days compared to how we used to do it. One thing that people should know is that we never do both eyes at the same time. And the reason for that is there's always a slight chance of infection with any surgery. And with cataract surgery, it's about 1 case in 2,000. So it's very, very rare, but it's not 0. And so that's why we do the surgeries on 2 different days. Next slide, please. So an interesting option with cataract surgery these days, and again, this has only been available for a couple of years, is the ability to do cataract surgery with a laser. And the laser that we use is called a Catalyst Precision Laser System. And the reason we like it so much is that this specific laser was built from the ground up just to do cataract surgery and nothing else. And that laser is used to make the incisions in the eye. And then it's also used to gently break up the cataract and help us remove it from the eye. So I always tell folks too, the incisions that this laser makes is more accurate than I am because I'm a human and it's a laser, and it is incredibly precise in what it does. The main thing that we like about the procedure is though, that it uses less ultrasonic energy inside the eye, and we think that that is a protective thing for the cornea. Next slide, please. So there's a couple of benefits from Catalyst that we like to tell folks about. One thing is it's a very comfortable procedure. There is no pain with this laser whatsoever. It's a very gentle procedure, and we can even use it to do interesting things like taking care of astigmatism and other things. Very precise, as we mentioned before. And the thing that's very interesting about it is when you are in the laser scans the eye, usually takes about 20 seconds, and then it produces a treatment plan for that eye that is unique to the individual. So it really is tailored to that individual's needs. And the nice thing too is that because we're using less energy inside the eye, people tend to get a little bit of a faster visual recovery with it. Next page, please, or next slide. So we also need to talk a little bit about what options are available with the lenses. 25 years ago, we just put a lens in and it didn't matter where people came up, they were just happy to be able to see again. Things have gotten a lot better. So when we talk to folks about what lens they're going to want, we give them a couple of different options. The standard option that we give, and this is the one that's covered by most insurance plans, is that we ask people which they would rather see better at without their glasses. Would they rather see better at distance, or would they rather see better at near, which is close up? The flip side, though, applies. If you want to be clear at distance, then you're going to be more glasses dependent at near. If you want to see good at near, then you'll be more glasses dependent at distance. And so we go into great deal about this because this can sometimes be kind of confusing to describe. Next slide, please. There are other options available though. So one of those options is a thing called a panoptic trifocal lens. And the goal of this lens, and it's only been available for a couple of years, is to give you good vision at distance, intermediate, and near. Now, nothing is ever going to replace the natural ability of the lens in the eye. We're taking the natural lens out, which is a disease process that we're treating, and we're putting in an intraocular lens to try to do something as good as that lens did before. Your brain is always going to remember being 20 years old and having crystal clear vision, and that's what that brain is going to want. And so our goal is to get you as close as we can. For the right people, the trifocal lens is a great option because it really really decreases dependence on glasses. And that type of lens is a type of multifocal lens. And if individuals are interested in that lens, we go into great detail about their visual needs to make sure that's the right thing for them. Another thing that we can do and frequently do is use lenses that can correct astigmatism. Now, astigmatism is when the cornea, that front clear window of the eye, is warped in some way. So instead of being completely round, for instance, like a basketball, it's shaped a little bit more like a football. It's got some warp to it. Well, toric lenses are a type of lens we can implant to get rid of that astigmatism because astigmatism causes blur in vision. And so if you're a candidate for that, we also discuss that type of lens. One thing to note, though, is with any lens selection, you always may need glasses to see your absolute best after cataract surgery. Again, we're treating a disease process and we try to maximize your vision as good as we can. Next slide, please. Another thing that's become available in the last couple of years is a thing called AURA, and that's an acronym that stands for Optowave Refractive Analysis. And it's a fantastic tool that we can use to try to pick the right lens to put inside the eye. It's a real-time measurement that's done after your cataract is taken out. So in other words, we do the surgery, we take out the cataract, and we then perform AURA to do a wavefront analysis of your eye, and it helps us pick the power of the lens to put back in your eye so we can get you as close to the visual outcome that you want. The lenses come in certain set sizes, that's how they're manufactured, and AURA and the calculations that we do before surgery help us pick the right lens to implant. Next slide, please. So as we mentioned, I'm a glaucoma specialist, and so not infrequently we see people that have glaucoma in addition to their cataracts. And within the last 4 or 5 years, we've started developing new technologies to try to help treat individuals while we're in there doing our cataract surgery anyway. So the eye stent is a very, very tiny device. It is much smaller than a grain of rice. In fact, it's the smallest implant you can put in the human body. And 2 little stents are inserted into the eye during surgery, completely painless process. And basically what these are doing is bypassing the part of the eye that has blockage that's making the eye pressure go up, because that's what glaucoma is. Glaucoma is when the eye pressure is too high for the eye and it causes damage. And the only way to treat that is get that eye pressure down. And if we're in there doing cataract surgery anyway, it's a great opportunity to treat the glaucoma as well. And so the eye stent is just a type of what we call micro-invasive glaucoma surgery because it's not a big bad surgery. It's just something that we add to our cataract surgeries. There are also other devices that are available as well. And when folks come see me, we talk about all the various options to see what you would like. And these things are almost always covered by insurance. So it's not a problem typically to put those in. Next slide, please. Okay, so we want to answer some questions that folks have. And I'm just going to start out with a couple of them, just kind of the usual things that people want to know. The big question, of course, in anybody's mind with any type of surgery is it safe? Is it something that they're going to come out of on the other side better off than they were when they went in? And so fortunately with cataract surgery, the answer is absolutely yes. Now, it is still surgery, and any surgery involves some risk because we never really know 100% until we begin the surgery how your eye is going to respond to the surgery. But complications from cataract surgery these days are very, very rare because the technology has gotten so good and the techniques we use have really advanced the surgery a lot. And next slide. So another question is, of course, does it hurt? It's your eyes after all, and we never forget the fact that we're working on eyes, and everybody is very protective about their eyes. The procedure itself is virtually painless. We put drops on the eye to begin with to numb the eye, and then everybody has an IV, and medication is given so that you know what I'm doing because we don't put you all the way to sleep, but you just don't care. It's like other surgical procedures that you can think of where you are anesthetized to have them done. There is little or no discomfort with these surgeries whatsoever. After surgery, the eye can be a little bit scratchy because you have had surgery, but that usually lasts only like a day or two and takes care of itself. And again, the surgeries are about a 10 or 15-minute surgery. They don't take that long. Next slide. Okay, well, what happens after the surgery? You know, what you do after the surgery is just as important as what is done during the surgery. And so because you're sedated, you have to have somebody drive you home. We usually recommend that folks take a nap when they get home. And for the first week, it's very important to wear a protective shield over the eye. And that's because we do all types of strange things when we're asleep. And one of the things we do is we can rub our eyes if our eyes become irritated. Well, if we've made some incisions in the eye, that's the last thing on earth we want anyone to do. So we have them tape a plastic shield over their eye at night to keep from having any problems. You're also prescribed eye drops, and those eye drops are antibiotics to keep from getting an infection, and also medications to control inflammation. Very important after the surgery is to avoid any strenuous activity. We don't want anybody lifting anything heavier than 10 or 20 pounds. And we absolutely don't want people swimming or putting their eyes at risk by being in a hot tub or anything like that for a couple of weeks. The reason for that is that you can get fungal infections and things like that. They're difficult to treat. So we also don't want folks to be in a dusty or grimy environment for about 2 weeks. And, you know, that's the trade-off for having a lifetime of good vision, but we have to be pretty strict about that to make sure folks aren't doing what they shouldn't be. Next slide, please. Okay, big question too. Does insurance cover cataract surgery? Well, traditionally, the basic surgery with a monofocal lens, and that's again that basic lens that gives you distance or near vision, is typically partially covered by your insurance or Medicare. Frequently, people have Medicare plus a supplemental insurance to cover those expenses. We're always very careful to have our staff look at what the insurance costs are going to be so that people know exactly what they're going to be paying. If you choose an upgrade, and that's if you choose Catalyst, or you choose that multifocal lens, or you choose to have Aura done, all of those things involve some out-of-pocket costs. And like anything else, when you're looking at various different options, there's always financing available with zero interest if people are interested in going that little bit of an extra mile, shall we say, to get some type of upgrade with their surgery. Next slide. Okay. So when you come in for a cataract surgery evaluation, we dilate the eyes because every surgeon needs to get a good look at that lens and see if there's anything going on we need to be concerned about. We also assess the eyesight, again, to make sure that your vision really is bad enough that you need to have surgery done. And we talk about your lifestyle and the various different options that would be available to you. And it's typically about a 1 to 2 hour appointment because there's some evaluation done. You then have to get a very good dilation, and then some additional testing that is done, and then a discussion of individual needs and what the patients want to have done. And again, we may recommend that you wait. Very frequently, folks will come in and we'll say, hey, you know, come back and see us in 6 months to a year, or, you know, whenever, if you feel that your vision has worsened over that time period. Next slide. When is it a good time to have surgery? Well, almost everybody these days has some type of significant deductible. And so if you've already met your deductible for the year and you notice that your vision is not where you want it to be, then it might be a good time to come in and get an evaluation because it might be a good time to have that surgery done. Next slide. Okay, so what other questions do we have?
All right, so I'm going to open up the questions. It looks like people were engaged throughout, so I'm going to start reading them. But if there is anything that comes up or additional questions, feel free to chat them now. And we're going to have about 10 minutes here with Dr. Burden to answer questions. Let's see. If someone has had RK or PRK and LASIK on their eye before, is Dr. Burden familiar with doing cataract surgery on post-operative eyes related to RK, PRK, and LASIK?
Absolutely. The partner that established this practice that I'm in was Dr. Buckley, and Dr. Buckley did a tremendous amount of RK and LASIK and PRK, and so we're very comfortable seeing all of his patients for cataracts. When you are doing cataract surgery on someone that's had refractive surgery, it is very different because that surgery alters the front of the eye forever. So There are specific machines that we use to measure the eye and get numbers that we need. And then when someone's had RK or LASIK or PRK, Aura, which is that device I mentioned that we use during surgery, is critically important because that really gives us really good numbers after that cataract is out to help us really hone in on the best vision. Um, RK was a great surgery. It usually gave people about 5 to 10 years of really good vision, but it does make those measurements on the eye a little bit complicated. And so those individuals typically will see better with glasses after their surgery, but we do still try to get them as good as we can without glasses based on the numbers that we get from our testing.
All right, and how do you immobilize the head during surgery?
So it's kind of interesting because you're sedated. People usually are very relaxed and don't really tend to move their head that much anyway. But what I do, and I do this primarily just to line folks up with the microscope because we use a microscope to do the surgery, is we simply put a 1 inch wide piece of tape across the forehead down to the headrest of the bed. And it's just enough pressure that people realize that it's there and they don't move. There are some conditions where people have significant head tremors, and in those situations, if it's significant enough, then we do put them all the way to sleep just to make the surgery safe. But that's very rare. Usually our anesthetics will take care of any movement.
So this is a very unique question. I've seen on Popular Science of a lens that can correct, I guess, digitally actually seeing better than an eagle. Um, and is that an option or is it still in development?
I have not seen something like that, so I would think that would have to be under development still. Typically, with the cataract surgery, we aim to get you back to the best vision that your eye can see. And for a lot of people, it gets them back to kind of where their vision was when they were maybe around 40, when they had really clear vision before they started developing cataracts or before they started needing reading glasses. But as far as something that is that specific, that would be something incredible, and I have not seen that yet.
Okay, and then can the surgery also treat floaters?
That's a great question because almost all of us have floaters as we get older. So the floaters are in the jelly that's behind the lens and in front of the retina, that nerve layer that lets you see. And the reason those occur is because that jelly is really solid, almost like Jello when we're born. But over time, it becomes more and more watery until the jelly folds in on itself, and that's where the floaters come from. So when we're doing cataract surgery, we never ever want to be in that area where that jelly is because it can complicate the surgery. We want the bag that the cataract is in to remain intact because that's where the artificial lens goes. Uh, Typically what happens is if you have floaters that really, really are causing you problems, and some folks have these floaters directly in their central vision, and it is very disabling, retina specialists can go in and remove that jelly in a procedure called a vitrectomy, and that can get rid of floaters. So people who are really suffering from that, there is an option. It just isn't done in cataract surgery.
Okay. This is a little bit more unique, and I'm going to kind of paraphrase here. But if someone had had a cataract procedure that had a toric lens many years ago, and they potentially weren't happy, but it's time for that second eye to occur, what would you recommend potentially there in to make sure that the patient is happy with that second eye? Um,
Okay, so when a lens of any type is put in the eye, as the months go by after the surgery, the bag that used to have this really big lens, and the lens is about the size of an M&M, shrink wraps the artificial lens implant because the lens implant's only about the thickness of a piece of paper. So once it scars into place, it is very, very difficult to remove the lenses without causing further damage to the eye. And so that's why if you've had a toric lens placed in the past, it's usually not a good idea to try to have that lens swapped out for another lens because that can cause some complications. As far as the second eye is concerned, the technology has gotten better as far as how to position those lenses inside the eye to take care of astigmatism. So I would advise the patient to still have a toric lens placed in their second eye to try to get them the best possible vision. But again, every person is an individual, and so that's something that would have to be discussed carefully after the examination.
Okay, does Medicaid cover part of the cost to insert the eye stent? And if you get eye stents, do you still need eye drops every night?
Okay, great question. Um, and I always get in trouble for talking about insurance for my billing people because every insurance plan is different. What I can say is that in general, uh, Medicare typically pays 80% of the cost of your surgery. And very frequently, it also pays 80% for the placement of eye stents. And then supplemental insurance picks up the additional cost, or people will choose to pay that price themselves uh, with the eye stents. But most insurances cover them these days, which is great. Um, Depending on the implant that you have put in, they are not 100% successful. And so I tell people straight up, when you have these devices put in, you have about a 50% chance that they're going to work for you. So for instance, let's take someone that has glaucoma, is on eye drops, and we're trying to get their pressure down to 15, shall we say. Once we do the surgery and we put in the eye stents, at the 1 month after surgery mark, if their pressures are looking good, we stop their drops and we monitor them closely for a couple of weeks to see what happens. And if those pressures stay low, then patients don't need their drops anymore. If it doesn't drop the pressure like we want it to, then unfortunately those folks are in the 50% that don't respond, and we just monitor them going forward. One important thing to note is even if the eye stents work great, patients still have to be monitored very carefully, because very commonly any glaucoma procedure we do in time may not be as effective, and so we always want to be sure that folks have the right pressure.
Okay, so if you have the surgery where the catalyst laser is not available, will you still have a good outcome? And is the aura part of the catalyst machine?
Certainly. So, before we had the catalyst laser, we just had the standard surgeries that we do. And standard ultrasound surgery is a great way to take out cataracts as well. Catalyst is just another option. Um, in our facility, when we do catalyst, we bundle the cost for aura into the catalyst price. Because if you're going to go for a premium product like that, we do everything we can to get you the result that you want. But Aura is a standalone device. It is not part of the catalyst laser. It's done in a different part of the surgery. And so that's why Aura is available to anyone, anytime, not just with the laser.
If my doctor indicates I'm getting cataracts but wants me to come back in 6 months to a year, why would I want to wait? How long between surgery are right and left eyes done?
Sure. So I think that because there is always a risk with any surgery, we always give folks the option, if they feel like they're functioning the way they want to, and they're not really having too much difficulty, of waiting to do the surgery later. Even though the risk is very, very small, it's not zero. But once a person's quality of life is impacted by their vision, then that's when we move forward with cataract surgery. And for some people, it can happen if their vision is dropped from 2020 to 2025. Other people come in with profound vision loss and tell me they're doing great. So it's just a personal experience all the way around. When we do the surgeries, we do them as close together as 2 days. If somebody has like a really high prescription and they're going to have double vision between getting the eyes done, or we do them as far apart as people want. Typically, people choose to do them about a week apart. And we like that because the greatest chance of infection after the surgery is days 5 to 7 after the surgery. That's why after the surgery, you come in and you're seeing the first day after surgery and then at 1 week. And so 1 week is a nice time between the two eyes so that you don't have a huge long recovery period, but also is a little more safe.
How long would you need to be out of hard contacts before cataract surgery?
Great question. With soft contact lenses, you just need to be out of them for a week for us to do all of our measurements, because that's the most important thing at the pre-op evaluation, is to get good numbers on the eye. With hard contact lenses, especially if folks have been wearing them for 30 or 40 years, it takes a while for that cornea to relax. And so sometimes they have to be out of their rigid lenses for 1 to 2 months until their eye relaxes enough that we can go ahead and do surgery. And if people are wearing contacts, they have to stay out of those contacts for the same amount of time before we can do aura during the cataract surgery itself.
Okay, if the YAG procedure is done by the laser to remove scar tissue from my previous cataract surgery damaged eye, could a catalyst laser surgery risk having similar outcome, leaving me with floaters that are permanent?
Ooh, okay, so there's a lot in that question. What that's referring to is a laser procedure that's done after cataract surgery. So when we take that cataract out, We do remove the entire cataract, and the cataract itself never comes back. However, we do leave the bag that was around the cataract behind because something has to hold that implant in place. 50% of the time, with any type of cataract surgery done with any type of device, that bag is going to cloud up, and we have to do a laser procedure to polish that out of the way. The nice thing is, once it's polished out of the way, it never comes back. And it's about a 10-second laser procedure. It is frequently done at a surgery center, but does not require sedation or anything like that. But 50% of people who have cataract surgery are going to get that clouding after the procedure and need a YAG. The YAG procedure itself may initially cause a few floaters, but the floaters that people have that impair their vision are typically not caused by the cataract surgery or by the YAG procedure. It's just the changes in the back of the eye when the jelly folds in on itself.
Okay, I have horses and live in a dusty area. Is there coverings I can wear over my eyes?
Yes. What I've seen some folks do in the past is almost wear, as crazy as it sounds, swim goggles. We're not so much concerned about dust that's blowing around in the air just if you go for a hike or something like that. If you're working, in an area where you have horses or cattle or something like that, we do have to be a little bit more careful. And typically, easy for me to say, but another thing to do is just take it easy for 2 weeks, because remember, you're getting a lifetime of visual correction, but you do have to kind of take it easy for a week or two.
Okay, so this I'm actually going to address one of the emails that came in beforehand here. Um, so, how successful is the multifocal cataract lens plant with patient satisfaction?
So and I know the exact answer to that, because when this lens first came out and it debuted at one of the big national meetings, they put up the statistics for it. And it's very interesting for people who choose that lens. If you ask them 6 months later if they would have the same lens implanted in their eye, it is 99%. Now, the key with those lenses is picking the right person for it. And this is why. Those lenses are fantastic at giving you intermediate distance and near vision, but they have one drawback. And that drawback is that by the way that the lens is designed to give you all those benefits, it does cause a little bit of glare and halo with pinpoint light sources at night. So if someone is very disturbed by glare and halos when they're driving, that might not be the right implant for them. And so we're very careful to go over all the risks and benefits with a multifocal lens to make sure it's right for the patient, because again, we never like to remove a lens after we've put it in. So it's a pretty extensive interview and discussion of that lens, because when everything is said and done, at the end of the day, when people come out on the other end of having the surgery, we want you to be happy. And so we're very careful to ask the right questions to see if those are the right lenses for you. If you're the right person for that lens, it's life-changing. It really, really winds the clock back to where you were almost like 20 and didn't need anything.
This kind of goes hand in hand, as I prefer not to have to wear eyeglasses and would like to have good distance vision in both eyes, yet still be able to read. Would you recommend the multifocal cataract lens implant?
So that is one option to do that for you. Other individuals choose to have one eye corrected for distance and one eye corrected for near. And we test folks very carefully to make sure that's a good option, because not everybody's brain will accept that type of correction. But again, depending on your needs and wants, a multifocal lens can be a great option. One thing I always like to tell folks is, regardless of the lens that we put in your eye, almost everybody will see just a little bit better with glasses after the surgery. But frequently people are independent of their glasses enough that they only need them for perhaps when they're reading like little tiny print on the back of a credit card, for instance. Or if one eye is corrected for near and one eye is corrected for distance, they have a pair of glasses that gets both eyes to distance for driving at night and things like that.
Okay, last question today. Any new developments on the horizon which would make me want to wait?
Boy, that's a great question. The holy grail with cataract surgery is to have an implant that, without any type of drawback, gives people distance, intermediate, and near vision. So in other words, something that replicates the natural lens as close as possible. And there's always research going on to get better and better lenses. There's even a type of lens now that is implanted, and then a laser is used to kind of get the vision better after the procedure. It's very definitely in its infancy, It's not something that's probably going to be on the horizon for 5 years, say, or 10 years. So there's always going to be something better around the corner, that's for sure. And so that's why we're always very careful to find out with patients, is it really time to have the surgery done or not? One thing I'll mention too is it is possible to wait too long to have cataract surgery done. And by that I mean, as we mentioned earlier, that cataract continues to grow the older we get. And so sometimes if people wait to have cataract surgery, perhaps into their late 70s or 80s, that cataract has become very dense and very hard. And it actually takes a lot more energy to get the cataract out. So typically we recommend for folks, once you become in some way visually impaired, in other words, you're noticing that your vision from your cataracts is decreasing, it's usually time to go ahead and get it done. Because very frequently when people have cataract surgery done, afterward they wish they'd done it 5 years earlier.
Perfect. Well, that's all the questions that have come in today. Just wanted to thank everybody for attending today. And if you have any questions or any additional things that come up, feel free to schedule a cataract evaluation. We'll also share any questions that came in with the cataract team, and they may reach out to you to better help answer questions that may not have been fully addressed here today. But Dr. Burden, thank you for your time today, and thank you everyone else for attending, and hopefully you found this webinar informational.
It was a pleasure. Thank you very much.
Thank you. Bye, everyone.